with immediate access to potential users around the world. Bayer is illuminating the path forward, generating results from a world full of potential. We're excited for the journey ahead. Let's take the next step together. We want to meet you. Schedule a meeting to share what you're developing.
My journey continues, and I know I'm not alone. Because together, we can make a difference every day.
Can we start? Can we start?
Hello.
Good afternoon, Professor and colleagues, ladies and gentlemen. Welcome to the 14th Congress of Asian Society of Echocardiography of Cardiovascular Imaging. We would like to start the session on multimodality in the evaluation and treatment of valvular heart disease. I would like to introduce my co-chair, Professor Bernard Vernet from Belgium.
Hello. Pleased to meet you. Well, thank you very much for the invitation.
Professor Bernard Gerbet, please introduce the speaker.
Okay. Just a second. I think the first speaker will be Professor Mark Black from Edinburgh.
Okay. So hopefully you can see my screen. Can you see, everyone see the screen?
Yes.
Okay. Well, firstly, thank you very much for the invitation today. It's a great pleasure to join you. Of course, I would much rather be in Vietnam personally, but this is the next best thing. And it's a great pleasure. So thank you for the invitation. And today I'm going to talk to you about assessment of aortic stenosis with CT. Now, of course, echocardiography is the gold standard assessment of aortic stenosis. And I think that will remain the case for the foreseeable future. And we use really 3 different assessments to assess valve severity. We use the peak velocity, the mean gradient, and the aortic valve area that we derive from the continuity equation. And of course, echo can also tell us about the myocardium function, the wall thickness, etc. And in the vast majority of patients, this is all we need. That's the only test that you need to confirm the diagnosis and to assess severity. However, in quite a high proportion of patients, these echo assessments don't agree. So we have disagreement between the aortic valve area and the mean gradient or peak velocity. And actually that occurs quite a lot in about a quarter to a third of patients. And that's true even in the best echo centers in the world. This is a study from the Mayo Clinic, Bichat Hospital and Montreal, top quality echo centers. Even with their expertise, around a quarter of patients have discordant measurements on echo. So we're not entirely sure whether they have moderate or severe stenosis. And only a small proportion of these are explained by the low flow phenomenon. So there is a group of patients where assessing aortic stenosis severity is difficult. And one potential solution to that problem is CT calcium scoring. So what does that involve? Well, for many years, we have attempted to grade the amount of calcification on the valve. And initially, we did this with echo. And you can provide a semi-quantitative assessment. So normal, mild, moderate, severe calcification. And even that basic assessment is useful. It can inform about faster rates of progression in the future, and it predicts events. However, we don't really use that all that commonly in clinical practice because it's difficult to get agreement on what is mild, moderate, or severe calcification, and the agreement is not particularly good. So CT has a major advantage in quantifying calcium. CT is really excellent at quantifying calcium, and of course, we use that all the time in the coronary arteries to derive the coronary calcium score. And essentially using exactly the same approach, we can also quantify the aortic valve calcium score. We can use exactly the same scanner, the same techniques, and the same software. Here is an example of the software that you should use. We need to be specific about the voltage used for the CT scan because that affects things. And we also need to be specific about the slice thickness and it needs to be ECG gated. So then we can start measuring calcium here, and there's a bit of a learning curve in doing this, and the key thing is differentiating calcium in the valve, here shown in orange, versus calcium in adjacent structures. So for instance, the mitral valve annulus, for instance, the coronary arteries. We need to do a good job of working out what is the valve and what isn't. And sometimes that can be tricky. So for instance, when there's continuity between calcium in the valve and the mitral valve annulus, that can cause difficulty. But generally, this is a fairly straightforward thing that can be learned over the course of an afternoon. And then we can get calcium scores. Now, it's important that we do the calcium scores using the axial planes, the traditional axial planes that you get. As soon as you start trying to reorientate planes into the plane of the valve, the calcium score changes quite a lot. You can see an example here where it's changed by over 1,000. So you have to do it in the axial planes. And if we do this, then CT calcium scoring is extremely reproducible. We get very consistent measurements, very consistent agreement in the measurements. And I think that is maybe its major advantage compared to other techniques, particularly when you're thinking about endpoints for clinical trials of drugs to target calcification and aortic stenosis. But more importantly than being reproducible, CT calcium scoring provides very important diagnostic and prognostic information. Really, a key advance in this area was the understanding that men and women need different thresholds for severe calcium. So women develop severe stenosis with lower calcium than men. And I think once we realized that, then everything became quite clear in the field. And so the cutoff for severe aortic stenosis for men is about 2,000 Agatston units, and in women, it's about 1,300 Agatston units. And if we use those cutoffs, then we get very good diagnostic accuracy when we compare to concordant echocardiograms. And actually, interestingly, we get very powerful prediction of future events. So actually, the calcium score predicts future aortic valve replacement better than echo, which is remarkable in some ways because we're using echo to make decisions about surgery. This was the first paper by the group of Marianique Clavel, and we read this with great interest and tried to then put together a validation study. So this was conducted across Europe and North America and involved over 900 patients. And as before, we saw that there was a different relationship between aortic stenosis severity and calcium in men and women. Again, men generally having more calcium in their valve than women. And when we looked across this cohort, we looked at what our best thresholds were in men and women for severe aortic stenosis. And they were pretty much exactly the same as had been proposed previously in a completely independent cohort. So again, about 2,000 for men and about 1,300 for women. And if you do that and you compare CT calcium scoring against concordant echo, i.e. echo where we're absolutely sure what the severity is, then we get a very impressive area under the curves of nearly 0.9. So, very good agreement and good diagnostic accuracy. Also, interestingly, your baseline calcium score is a powerful predictor of future progression in calcium and valve hemodynamics. And that points a little bit to the underlying pathology that I think in severe and probably moderate aortic stenosis, we have this vicious cycle of calcification causing abnormal stresses in the valve, causing injury, causing more calcification. So calcium begets calcium. And because of that, your baseline calcium score predicts activity and it predicts future progression. And then it predicts clinical events. So again, like Marianique Clavel showed, a very powerful prediction of future events, the most powerful prediction of future events, better than other risk factors, age, and all the echo assessments. So I think in summary, we're at a stage where CT calcium scoring has been validated now in big cohorts. There's a validation in an Asian cohort I'll come to in a second. And we know that it's got good diagnostic accuracy, that it provides a very powerful prediction of disease progression and clinical events. And I think it's time to use it. And This is reflected in the guidelines. These are the Esc Guidelines from 2017. There's some new ones coming out a bit later in the year. And essentially, they propose that you use it in patients with discordant echocardiograms. If you've got low flow, then you can use stress echo as well. But if you don't, then calcium scoring can play an important role. So what about those discordant patients? Is it useful in that subgroup? Well, it's quite interesting if you look at them. There's a lot of variation in the discordant group according to calcification. So some have severe calcification, some have non-severe calcification. So it's pretty hard to predict, even in these subgroups, who's going to have severe disease and who's not. But crucially, if you look at outcomes in that subgroup, then again, calcium score predicts outcomes in patients with discordant disease. So I think it is a useful arbitrator in these patients where the echo is not clear. And also, it is a useful mark of disease progression. So one key attribute is that it's very reproducible, but the annualized change is high. And so we can measure change over time with greater accuracy than we can with echo, where the error is quite high in the measurement and the annualized progression is quite low. This is the study I was talking about, looking at Asian populations. So this just came out recently in EHJ CVI. And again, if you apply these same thresholds, 2,000 and 1,300 to Asian populations, you get good diagnostic accuracy and prognostic information. So I've just told you how good I think calcium scoring is, and I think it is a very good technique. However, as with everything, there's always the new technology on the horizon, and in the coronaries, we have moved really from non-contrast imaging to contrast CT, and I think we might do the same with the valve in the future. So there are some patients where calcium scoring clearly gets it wrong, and these are patients that are usually younger, female bicuspid valves is the classic example, who have severe aortic stenosis, unquestionably, but have very little calcification in the valve, and their pathology is different. And it's more about fibrosis rather than calcium. You can see an example here, very low calcium scores, but a lot of non-fibrotic thickening. And of course, calcium scoring misses this. And what we can do, however, is look at contrast CT, where we can see both calcific thickening and non-calcific thickening. And we can now develop thresholds to differentiate these two things and to measure them. And so you can have a score for calcific thickening and for fibrotic thickening, and you can put them together, this concept of the fibrocalcific score. If you look at its correlation with CT calcium scoring, then our assessments of calcium on contrast CT are similar. And if you look at the ratio, we get some interesting observations. So what happens to the balance between calcium and fibrosis? Well, as expected, men have more calcium than fibrosis in their aortic valve, but actually it's the opposite for women, who have more fibrosis and less calcium in their valves. And if you look across severities, then the amount of calcium seems to increase. So if in patients with mild AS, actually there's more fibrosis than calcium, but overall in severe AS, the calcium predominates. So it suggests that you go through a phase of early fibrosis and later calcification as a general phenomenon. As I said, you can combine the calcific score and the fibrotic score together to get a fibrocalcific score, and this shows a clear increase with severity. And actually, the interesting thing about it is that it starts to improve correlations with your peak velocity, particularly in women, where the calcium score doesn't often show a great correlation with peak velocity. You can really improve that because all of a sudden you're measuring the fibrosis that is an important component of the disease. And now we've got very nice software to do this rapidly. We can do this assessment in about 2 or 3 minutes and get these highly reproducible and beautiful images. So I think actually this is the future. Calcium scoring is here now, and I think we should be using it now, but I think in the future we may well evolve to using contrast CT. Okay, these are just some other examples of us quantifying different bits of pathology in different valves, both native and prosthetic valves. So in conclusion, echo is the first line to assess aortic stenosis. However, in an important proportion of patients, there are discordant measurements and we're not quite sure if they have moderate or severe stenosis. In those patients, I think CT calcium scoring is an excellent and elegant answer to that issue, can help decision making. And I think in the future, that may well evolve to use of contrast CT, but we'll see how that evolves. Thank you very much for your attention.
Thank you very much, Mark, for this excellent presentation. And I think the next presentation is going to be the presentation by Dr. Roy from Vietnam, who is going to talk about echocardiography in evaluation and treatment of valvular heart disease. Please, Dr. Roy.
Sorry. Good afternoon, Professor and college. Ladies and gentlemen, I am Dr. Hoài Nguyễn from Vietnam. My topic today is echocardiography in the evaluation and the treatment of valvular heart disease. I have no disclosures. You know that in recent years, there have been tremendous progress in the diagnosis and the treatment of valvular heart disease. And decision-making for cardiac surgery and intervention should be made by a heart team. And what we learned from the last trial, such as partner or co-ops, is that the heart team is made of all the components in which cardiac imager plays an important role. And you can see that echocardiography has a new role in understanding the pathophysiology of valvular heart disease, in the development of best practices within valvular intervention and surgery. And there have been many innovations within valvular heart disease regarding aortic valve, mitral valve, and tricuspid valve. Now we talk about aortic valve. I want to focus on aortic stenosis, which prevalence which is increasing due to the old population. And we can see that clearly the definition of different stages, they come from imaging. Symptomatic severe high gradient aortic stenosis is obviously concordant with echocardiographic measure of aortic valve severity. But we have some patient who has a discordant measure. Patient with small valvular area calculated by continuous equation, but mean gradient is still low. In this setting, we have a reduced ejection fraction, so we call them low gradient aortic stenosis. And we also have the paradoxical low flow severe aortic stenosis, in which EF is still normal. Em ơi. Sir, it's okay. Sorry. And we know that low flow, low gradient aortic stenosis is defined when ejection fraction less than 50%. And dobutamine stress echo is used to reveal whether the patient has true severe aortic stenosis or not. And we go down to the pathway, we track down to see if the patient has contractile flow reserve or not. If the patient has contractile reserve and the gradient is increasing during the stress echo and the valve area is still narrow, so we have a true severe aortic stenosis. If the gradient is still low and the valve area is up to moderate range, so we have pseudo-severe aortic stenosis, and we only do medical therapy for the patient. And if the patient has no flow reserve, it is sometimes very individualized, because we don't know, should we send the patient to the surgery or we should not. It depends on each individual patient. And regarding the patient we are treating, we can see that they frequently have a severe hypertrophic left ventricular wall, and they have a diastolic dysfunction. And also they have a fibrotic NV wall, so they have an abnormal NV mechanic function. And because of that, the stroke volume is low, and especially when the patient have tachycardia, the ejection time is very short, and so the stroke volume is reduced. Besides, the patient is elderly and they have a stiff arterial tree, so they often present with hypertension. And also they may have a concomitant valve disease like mitral valve regurgitation, aortic valve regurgitation, or tricuspid valve regurgitation, which make the NV and RV dysfunction worse. So in the newest guideline by Dr. Katrin Otto, we should optimize the blood pressure before assessing the patient. And we can use low dose the vitamin stress echo with reduced ejection fraction. And of course, like Professor Mark Drake has presented in the previous presentation, aortic calcium score is extraordinarily helpful in determining if the patient has a true severe aortic stenosis, and we have a cutoff for male and female. And ESC and EACTS has published the guideline in which show the criteria that increase the likelihood of severe aortic stenosis in patients with aortic valve less than 1 centimeter square or mean gradient less than 40 millimeter mercury in the presence of preserved ejection fraction, looking at clinical criteria like a symptom like OH, and qualitative imaging data like NV hypertrophy or reduced GNS, or quantitative imaging data using gradient, valve area, stroke volume, and of course, calcium score by MSCT is very helpful. In this slide, you can see that this is the graph showing the graph of the patient progression from non-severe aortic stenosis to very severe aortic stenosis. And you can see that there is a really narrow green zone of optimum timing, and that we frequently get to the patient too late. We often wait for the patient to have a symptom like a syncope or heart failure symptom, or they have an increased perioperative risk or increased risk of mortality, or even we don't want cardiac sudden death. So the optimum timing before the NV get decompensated is very crucial, but it is very difficult to understand because so that's why we cannot look only to the valve or to the leaflet. We also have to look to the ventricle. So we look at the asymptomatic patient. So in the guidelines, the newest guideline, with the asymptomatic aortic stenosis, if the patient has the ejection fraction less than 50%, or they are at the time of cardiac surgery for other indication, so they are at the class 1 for valvular replacement. But there are many studies showing that even when the ejection fraction less than 60% or less than 55%, they have a poorer outcome. So Katrin Otto recommends that we can consider sending the patient to the surgeon or to the TAVR if the ejection fraction is less than 60%, class 2B. And back to the ventricular fibrosis, we all know that with the long-standing stimulus of pressure, the ventricle will have both interstitial diffuse reactive fibrosis as well as focal replacement fibrosis. So we can learn that echocardiography can help to detect patients who have mechanical dysfunction. We can investigate the global longitudinal strain, And if the patient has the ejection fraction less than 60%, we can send them to the aortic intervention. But if they have the ejection fraction more than 60%, we can use the NVGNS. And if the NVGNS is worse than 16%, we should evaluate the patient with cardiac MR. This is a patient with very severe aortic stenosis and preserved ejection fraction 64%, but the GNS go down to 60%. And so this patient, we should send the patient to the cardiac MR to evaluate and to see if we should replace the valve earlier or not. And you know that in this slide shows some example of a device that had been made in development or still in the development on the trials. And let's talk a little bit about paravalvular and valve sighing in TAVR. In the old day, we use parasternal long assist field, and this is not accurate because with 2D we cannot get the accurate assist of the valve. So we should use the 2D TEE or 3D TEE or better MSCT to visualize and to assess the NVOT better, because you know that NVOT trace is elliptical, and in aortic stenosis it becomes more and more elliptical, and so if we only use echocardiography, we cannot assess it accurately. And now in many labs and in our lab, we don't need transesophageal echo to guide the procedure of TAVR, especially in COVID time. We just use fluoroscopic imaging for deployment of the valve. But back in the old day, when we still use TEE in TAVI, we can see that with TEE, it can be very helpful in many steps of the procedure, like a stepwise position, like a pacing wide position, or positioning of the valve, or to assess the aortic regurgitation after deploying the valve. And also we use echocardiography to search for thrombus, in prosthetic valve by TE or by TEE. Now, what about mitral regurgitation? The new guideline recommend TEE and cardiac MR as class 1 for initial diagnosis for chronic MR. And for primary mitral regurgitation, patients with high or prohibitive risk with anatomy favorable for transcatheter approach and life expectancy more than 1 year, we should send the patient to transcatheter H2H mitral valve repair class 2A. And in 2020 ACC consensus for management of mitral regurgitation, exercise echo was added to the list of ancillary testing that may be considered to establish severity of mitral regurgitation, and transcatheter treatment was extended to secondary MR up to if the patient had a persistent symptom, despite of optimal medical therapy for heart failure with reduced ejection fraction. And how about classification of the MR patient? We still use Carpentier classification, which is looking at etiology, lesson, and dysfunction of the valve. And we have 3 mechanisms of the valve regurgitation. Type 1 is normal leaflet with annular dilatation or leaflet perforation. Type 2 is increased leaflet motion, and type 3A is restricted leaflet motion, for example, mitral stenosis or inflammation, and type 2B is restricted leaflet motion in systole, in ischemia, or in myocardial infarction patient. So in the assessment of severity of MR, we use the guideline from American Society of Echocardiography and also the guideline from Esc and the 2020 guideline from AHA-ACC. And all the guideline look at the vena contracta, ERA, regurgitant volume, and the American guideline also look at regurgitant fraction. And we should note that 2D PISA often underestimate through ERA by 3D because with 2D we can only assess in one plane. And in some cases, in many cases, cardiac MR is very effective and accurate for assessment of mitral valve anatomy. This slide shows the device for my transcatheter mitral valve repair, and I'm not going to talk about this. And for primary MR, this patient has a posterior leaflet prolapse at P2, and this is a patient with dilated annulus, and this is the secondary MR due to ischemic cardiomyopathy. And in this patient, we often misdiagnose as the MV prolapse because the anterior leaflets often override in the posterior leaflets. And this is a mitral clip procedure under the guidance of a 3D echocardiography. And this patient had 2 clips, and you can see that the MR reduced significantly. And despite of difficult anatomy like annular calcification, perforation, large flame wide or large flame gap, or multi-segment pathology, with 3D echocardiography, we can do mitral clip successfully, except for perforation cases. Almost all the case underwent TEER with residual MR less than grade 1. And sometimes we can use multiplanar reconstruction that allow perfect alignment of 2D image with 3D anatomy. Very helpful. And in many advanced ecosystem, we can have many innovation to help to visualize the valve more naturally. What about tricuspid regurgitation? We have a study of Dr. Nas et al. Published in JICC in the year 2004, in which we can see that patients with severe tricuspid regurgitation and moderate tricuspid regurgitation has a poorer outcome compared to patients with mild and patients without tricuspid regurgitation. And Dr. Jack et al. Published in JICC in 2017, showing that the volume number of patients with tricuspid valve surgery increasing over the 10 years of the period of study, including valve replacement and valve repair. But the mortality is just up and down and quite stable. So we can see that there may be more room for tricuspid valve intervention here. And this slide showing the causes of tricuspid regurgitation according to 2020 ACC AHE guideline. We have a primary and secondary causes. And to understand when the causes of tricuspid regurgitation is very important for choosing the intervention of the surgery, the way of surgery to treat the tricuspid regurgitation patient. And this is the 2020 ACC AHA guideline for tricuspid regurgitation. And you can see that the patient will have a 4-stage A, B, C, D. Stage A is at risk, so we won't talk here. And stage B is a progressive TR, which is not very severe. We have a severe TR with asymptomatic and symptomatic. And this is the 2020 ACC AHA tricuspid regurgitation guideline, in which we make the decision based on the severity of the TR and if the patient had the right heart failure or they are at the time of left side valve surgery. So all the steps are based on echocardiography and cardiac imaging. And in 2017, Dr. Rebecca Hahn proposed a new grading criteria for the tricuspid regurgitation. She proposed two more grades, massive and torrential, not only based on color flow and the appearance of the flow, of the regurgitation flow, but also based on vena contracta, EROA, and 3D vena contracta or quantitative EROA. So this is not used in clinical setting yet, and we will wait for more study in the near future, and this is what we will discuss more in the future. And why is it important? Look at the study from Dr. Miura in JICC in 2020, and we can see that patients with massive or torrential TR have a difference in outcome compared to patients with severe TR. So it suggests that we should pay more attention to patients with massive and torrential TR, and this is the room for transcatheter tricuspid intervention. And this is the graph of tricuspid valve anatomy by Mayo Clinic, and we can see that this is a very classic graph and idealized graph. The valve has a three leaflets, with anterior leaflet is close to the aortic, posterior leaflet close to the coronary sinus, and the septal leaflet close to the atrial septum. But Dr. Hahn's rationale on intervention for tricuspid valve, so she proposed an anatomical nomenclature using 4 types of morphology of tricuspid valve, and the valve has up to 5 leaflets. And again, this is not used in the clinical setting yet, and it is not in the guideline neither. And we will have more to discuss about this in the near future. And to visualize the tricuspid valve, when sometimes with the 2D echo we cannot differentiate which leaflet is posterior or septum, so we can use soft assist view 3D echo, or we use 3D TEE. So with 3D TEE, we can visualize the posterior, anterior, and septal leaflet quite well, especially when we use 3D echocardiography, 3D transesophageal echocardiography. We can have unfast view of the tricuspid valve from atrial view and from right atrial view and from right ventricular view, which is very helpful. And sometimes we can use multiplanar reformatting, and we can visualize when both the anatomy and the regurgitation flow, and we know when the mechanism of the regurgitation. This is a patient with the cardiac pacing lead, and we can see that, and he has the tricuspid regurgitation. And in the unfast view 3D, you can see that the lead is in the center of the orifice, of the valve orifice, and it moved to the commissure. So this patient do not have impingement of the lead on the leaflets, and we can make sure that the mechanism for TR is a dilatation of the annulus. And this is a slide of the trick clip. We use the 3D echo to guide the procedure. And after the procedure, we can assess the result of the procedure, and you can see that the regurgitation reduced significantly. This slide shows the landscape of transcatheter tricuspid device. We have a direct suture and annuloplasty, direct ring annuloplasty, coaptation enhancement, and valve replacement. And Dr. Asmarat published an article in JACC 3 years ago. He suggests a strategy for choosing procedure based on primary and secondary TR. This is the first recommendation based on primary and secondary TR, and each type of TR he suggests appropriate procedure. So we can see that echocardiography and cardiac imaging is very helpful in helping us to choose the strategy for intervention. In conclusion, valvular heart disease is complicated and valvular heart imaging is complex and imaging can be challenging. 3D TEE plays an important role in the evaluation of valve anatomy and function. New indication for treatment of asymptomatic valvular patients based on echocardiography parameters. We have a new anatomical nomenclature and regurgitation severity that may be in horizon with clinical implication. Echo-based imaging is critical for transcatheter intervention. Thank you very much for your attention.
Thank you very much for this very comprehensive and very excellent talk, Dr. Y.
Em ơi, chị bị mất. Chị bị mất. So to continue, I would like to introduce Professor Bernhard Gerber from Belgium to give the next topic on cardiac MRI in evaluation and treatment of valvular heart disease.
Thank you very much for this introduction. Good morning. I would like to thank you for inviting me to give this talk about the role of CMR in evaluation and treatment of valvular heart disease. I do not have any conflicts of interest to declare. CMR is a very versatile technique which, by multiple pulse sequences, allows to evaluate not only cardiac anatomy, flow and function, and vessel anatomy, but also has the unique ability to provide detailed tissue characterization with determination of water content and evaluation of focal and diffuse myocardial fibrosis and ultrastructure. In the setting of valvular heart disease, CMR has particular advantages. Indeed, it doesn't have any restrictions to image multiple planes of valvular anatomy and function. For instance, for the aortic valve, you can prescribe planes individually to image the different cusps and to visualize the anatomy and morphology of the valve and to detect tricuspid, bicuspid, and quadricuspid valves. For the mitral valve, multiple planes can be prescribed to image the individual scallops. And this allows to detect prolapses and restrictions in valve planimetry with similar precision as 3D transesophageal echocardiography. CMR also has excellent visualization of right heart valve disease, such as the pulmonary and tricuspid valve. A particular advantage of CMR is that it allows accurate detection of left and especially right ventricular volumes, function, and mass. For the interpretation, there exist normal values according to gender and age, and interpretation algorithm, which allow to define if measurements are normal, borderline, or abnormal high. In particular, CMR has the advantage of having highly reproducible measurements with less interstudy coefficient of variation than echo and smaller detection of changes, and this is of particular advantage of following patients over time. Another important advantage of CMR in valvular heart disease is its accuracy and reproducibility for measuring regurgitant volumes. For the evaluation of aortic or pulmonary regurgitation, this can be done directly by phase contrast measurements in the aorta or pulmonary artery, and then you can measure forward flow and regurgitant flow directly. For the mitral and tricuspid valve, you need to use an indirect approach where you compare the stroke volume of the left ventricle measured by Simpson's method with the volume going into the aorta or pulmonary artery measured by phase contrast technique. You can also compare the left and right ventricular stroke volume, but this requires that there's only a single valvular disease. All these measurements have extremely high reproducibility and the advantage of not being limited by eccentric jets, multiple jets, telesystolic jets, paraprosthetic leads, or non-circular PISA morphology. Valvular stenosis can be evaluated by two approaches. Stenotic valves can be evaluated by direct planimetry by prescribing planes through the valve, and then you can measure the opening of the valve, but you can also use a continuity creation approach similar to echo, where you measure the flow velocity at the vena contracta and at the left ventricular or right ventricular outflow tract. Both measurements are highly accurate and correlate extremely well with echo, but you have to take into account they don't give the same results, as planimetry always gives slightly higher values than continuity equation. This is related to the fact that they don't measure the same orifice. Continuity equation measures the vena contracta instead of the anatomical orifice, and these are related by, this is smaller and related by a coefficient of contraction about 80%. There are also now new 4D flow techniques which allow measurements of flow and velocity at any plane and location, and these are particularly valuable for evaluation of multiple valve disease. Also, they allow to follow the mitral valve and perform direct measurements of mitral regurgitation. CMR is also feasible and safe in all patients after valve surgery. Whether patients had valve repair with annuloplasty rings, mechanical stented bioprosthesis, or TAVI. Due to these advantages, CMR is particularly valuable for quantification of mechanism or severity of disease, in particular for patients where echo is in doubt, and especially for regurgitant severity in asymptomatic patients. Indeed, echocardiography may have limitation for evaluation of regurgitant disease. If you look at the guidelines, it's in this slide, for mitral regurgitation, the guidelines propose an integrated approach using data from 2D and 3D imaging, as well as Doppler measurements of regurgitation severity. And both the vena contracta vis and the PISA method should be used, and adjunctive parameters help to consolidate about the severity of mitral regurgitation. This means that there is actually no optimal method, and that you may have discordant findings between different approaches and be in doubt about the severity of the real regurgitant. Especially, PISA method has some assumptions. It assumes that the jet is hemispheric in one orifice, constant over time, and its main limitation is that this is made by a a single dimension method which is squared and which increases the error. So if you make a 1 millimeter error in pressure measurement, you can go from a moderate to a severe or a mild regurgitation by changing values, as in this example, by a high approach. Also, PISA is not valuable when you have prolapse with systolic mitral regurgitation, when you have constraints of the PISA, or when you have multiple jets or elliptical vena contracta, like in functional mitral regurgitation. For these reasons, echo has relatively poor inter-observer and test-retest agreement. In this study, 16 patients with mitral regurgitation were evaluated by 18 cardiologists from 11 different academic institutions in different countries, and it was found that the inter-observer agreement for severity was only kappa between 28 and 37%, meaning that there was only 44 to 56% agreement of mitral regurgitation severity in expert hands. Also, test-retest agreement is poor. In this study, 23 patients underwent mitral regurgitation measurements at 2 sites within 14 days. And you can see the reproducibility was only 60% and the variability 25%. We also studied in this study the reproducibility of CMR and echo for mitral regurgitation quantification. You see here on this Bland-Altman plots that CMR had much better reproducibility, inter-observer reproducibility, less coefficient of variation than 2D echo. Also, CMR evaluation of mitral regurgitation better predicts evaluation to surgery than measurements of LV volumes and echocardiographic rating. This was shown by this study by Meyerson, who followed 109 asymptomatic patients with at least moderate mitral regurgitation and echocardiography, and over a follow-up time of 2.5 years. And you can see that CMR highly predicted the outcome of these patients, either by measuring regurgitant volume or regurgitant fraction, whereas ERO by echo did not. Also, in this study by Pellica, in 258 asymptomatic patients with mitral regurgitation, organic mitral regurgitation, who had CMR and echo, CMR better predicted the outcome of mortality indication for mitral valve surgery than echo, and with higher area under the ROC curve than echo, who had poor predictive value. The same is also true for aortic regurgitation, where there are difficulties for evaluating the severity of aortic regurgitation, especially if there's eccentric jets and when you have different approaches from the parasternal or apical view. When you have these prolapses, like in bicuspid valve disease with very eccentric jets, when you have paraprosthetic leads, calcified valves, or in evaluation after TAVI. CMR was found to better predict time to surgery also in aortic regurgitation. In 113 patients with moderate to severe aortic regurgitation over 2.6 years, Meyerson all demonstrated that CMR, regurgitant fraction, or LV diastolic volumes were able to predict time to surgery because over time. Also, in patients after TAVI, CMR was found to better predict outcome than echo. Actually, in this study by Fibro and all in Jack, 2016, CMR predicted evaluation of aortic regurgitation, predicted all-cause mortality or all-cause mortality and heart failure hospitalization, whereas echo did not. CMR also plays an important role in the evaluation of vessels. This is particularly important in aortic regurgitation, where the evaluation of the aortic root diameter is a criteria for surgery. You can see that CMR allows a very precise evaluation of the aortic root at all levels. You have full access to the entire aortic ascending arch, and you can perform measurements at different levels, like the sinus of Valsalva or the aortic root, and there are normal graphs for this dimension according to age and sex. Using contrast-enhanced CMR, you can also see the descending aorta and the abdominal aorta and the iliac vessels, and this allows to evaluate patients for accessibility for TAVI planning. CMR measurements of aortic root and annulus are similar precise than CT, and this may be of use when evaluating patients for TAVI. Last but not least, CMR offers the unique ability to evaluate the myocardium in patients with valvular heart disease. In aortic stenosis, presence of focal fibrosis by late gadolinium enhancement has been described and validated against histopathology. And the severity of this late gadolinium enhancement has been shown to predict overall survival as well as post-operative survival. Patients who have this late gadolinium enhancement suggesting adverse remodeling have worse outcome, and this suggests that the patient should be operated before such adverse remodeling occurs. CMR can also detect diffuse fibrosis by measuring of gadolinium-enhanced extracellular volume or by measuring the T1 time of the myocardium using log-locker sequences. This has also been validated versus histopathology. You can see this correlates with the degree of interstitial fibrosis, and also the increase of interstitial fibrosis measuring by extracellular volume or by T1 time was found to predict outcome in patients pre and post-operatively to aortic with aortic stenosis. Also in mitral regurgitation, you can detect the scar, and this is particularly interesting in patients who have functional mitral regurgitation, because you can demonstrate the mechanism of scar and the mechanism of functional mitral regurgitation, demonstrate the necrosis of papillary muscles, and also in this setting it was found that presence of scar predicts worse outcome in patients. Focal fibrosis also is a parameter which seems to predict arrhythmogenesis in patients who have mitral valve prolapse. In this study by Basso et al. And Perazzolo, it was shown in 356 patients with primary mitral regurgitation that scar may occur close to the mitral annulus, and patients who had such scar had higher prevalence of arrhythmia, ventricular tachycardia, fibrillation, or sudden cardiac death than patients who didn't have any scar. And presence of scar was found to be an independent parameter for predicting arrhythmic events. Finally, also extracellular volume severity and expansion was demonstrated in mitral regurgitation in correlating with the severity of mitral regurgitation. And also this parameter was found to predict outcome of patients with primary mitral regurgitation in addition to mitral regurgitation fraction. Overall, CMR plays an important role in multimodality evaluation of valvular heart disease. So you can evaluate it, the hemodynamic severity, the valvular anatomy, and the coexisting myocardial or vascular disease. It has an important role for risk stratification by this LGE, T1, and ECV model demonstration, and can demonstrate adverse ventricular remodeling. And CMR may also be useful for procedural planning by demonstrating indications for intervention, annular, and by allowing measurements of annular and valvular sizing. So in conclusion, I believe that CMR is complementary to echo for evaluation of valvular heart disease. This is because it allows comprehensive assessment of valvular disease, in particular more accurate evaluation of regurgitant volumes, which better predict outcome than echo. It's therefore useful, especially when echo is in doubt about the severity of regurgitation. CMR is also superior to evaluate LV remodeling in valvular disease and to serially follow patients for LV enlargement, hypertrophy, and deterioration of systolic function. It also allows comprehensive assessment of vessel anatomy, which is of particular value for aortic valve disease and for patients who may be candidates for TAVI. And finally, CMR allows identification of focal and diffuse myocardial fibrosis in valvular disease. And this identification of fibrosis provides additional prognostic value in valve disease and will probably be used in the future to time the optimal time of intervention in these patients. Thank you very much for your attention, and I'm listening for your questions. Thank you.
Thank you so much, Professor Berhard-Gerber, for sensational presentation, which gave us a very comprehensive and profound review of the role of cardiac MR in valvular disease. And we appreciate that cardiac MR is highly accurate in diagnosis of valvular heart disease, as well as to assess the severity and prognosis of valvular heart disease. Thank you very much, Professor. And may I introduce the next speaker, Dr. Sang-Gun Cho from Korea, who will speak about nuclear imaging.
Greetings, Esc participants. Congratulations to the successful Congress. It is a great honor to have a talk on this session with the global outstanding experts. Thank you for having me here. I'll talk about the roles of nuclear imaging in the evaluation of valvular diseases. I'll focus on 3 nuclear imaging modalities: sodium fluoride PET, FDG PET, and bone scintigraphy. The first part is about the use of sodium fluoride PET in aortic stenosis. F18 sodium fluoride is known to bind to actively calcifying bones by forming fluorapatite, the beautiful pinkish crystal here, at exposed regions of hydroxyapatite crystals. It is rich in shark teeth, which are repeatedly replaced for the lifetime of the shark. And you can easily find it at home in the toothpaste you use every day. And the uptake of sodium fluoride reflects the activity of calcification, which was represented by tissue non-specific alkaline phosphatase and osteocalcin in a previous study by Dr. Dweck and his colleagues. And here you can see the positive correlations between the surface area of the valves stained with 2 biomarkers with the sodium fluoride activity, which was measured as mean TBR on the PET images. When compared in the atherosclerotic plaques, sodium fluoride uptake well correlated with the calcification staining with alizarin red. Here, the yellow masks represent the overlapped areas between the red histologic biomarker staining and the green sodium fluoride uptake. And it was the largest for the alizarin red as compared to other vascular biomarkers. And the uptake of sodium fluoride was significantly higher for microcalcification as compared to macrocalcification, which was considered due to the internalization of hydroxyapatite crystals, and as well as the smaller surface area of hydroxyapatite crystals for macrocalcifications. When we obtain the sodium fluoride PET images of the heart, we can visualize the microcalcification activity from various parts of the heart. Here you can see the vulnerable plaques located in the aorta and the coronary arteries. And here you can see the valvular calcification. And interestingly, you can see the infarcted papillary muscle showing high sodium fluoride uptake because the infarction can induce the dystrophic calcification. Microcalcification is related to future gross calcification, which can be seen on CT. Even in the absence of baseline calcification, the positive uptake on sodium fluoride PET could predict future incident calcification after 2 years of follow-up. And when there was a baseline calcification on the valves, the positive sodium fluoride uptake could predict further calcification in the correlating sites. And the uptake of sodium fluoride reflects the severity, the hemodynamic severity of aortic stenosis. As you can see on the left side, the uptake of sodium fluoride increases parallel to the disease severity, while that of FDG did not change remarkably. And the correlation coefficients are also higher for sodium fluoride as compared to FDG PET when correlating with peak aortic jet velocity. Another beauty of sodium fluoride PET is that there is no physiologic myocardial uptake. As you can see on this image, the uptake measurement can be performed for the whole valvular structure in contrast to FDG. FDG has a significant physiologic myocardial uptake, which can be encroaching into the valve. So the measurement should be limited to the valve center to maintain the measurement reproducibility. Here on the right side, you can see that the uptake measurement is quite variable when the whole valvular structure was used for the measurement, but when they limited the measurement region of interest to the center valve, the measurement reproducibility improved. In this interesting study, they evaluate the value of sodium fluoride PET both ex vivo and in vivo. On the left side, in this ex vivo study cohort, the uptake of sodium fluoride on the valve well correlated with the calcification stain here, black colored here in the explanted valves. And in the in vivo study cohort, the uptake of sodium fluoride was well co-localized with the CT pathologies in patients such as CT calcification and non-calcific leaflet thickening and pannus formation. But in some patients, there was no correlating CT pathologies to the positive sodium fluoride uptake, showing that there can be some occult microcalcification going on without gross evidence on CT scan. And the uptake of sodium fluoride the valvular uptake on sodium fluoride PET showed significant linear positive correlation with the annualized change in valvular peak velocity. And here you can see that the uptake was significantly higher for patients having severer structural valve degeneration. And in the multivariable analysis, the sodium fluoride PET qualitatively or quantitatively showed independent correlation with the annualized change in peak valvular velocity, showing that PET could predict the changes in hemodynamic severity after a surgical AVR. The second part is about the use of FDG PET in prostatic valve endocarditis. The diagnostic criteria of infective endocarditis, i.e., have changed according to the development of imaging modality. Here, the von Rhine criteria was changed to the Duke criteria in 1994 as the two-dimensional echocardiography was introduced into the clinical field. And the modified Duke criteria in 2000, its transition was also based on the introduction of transesophageal echocardiography. However, the currently used modified Duke criteria has a limited sensitivity in prostatic valve endocarditis and device infection. Another problem is that, as this meta-analysis shows, surgical treatment may be significantly better for prostatic valve endocarditis as compared to medical therapy with antibiotics. So, the accurate diagnosis of prostatic valve endocarditis is really critical because reoperation of open heart surgery is not an easy deal for both patients and doctors. So in this context, FDG PET can be a valuable adjunct diagnostic modality because it can reduce the number of equivocal diagnoses in the initial evaluation of infective endocarditis. Here in this study, you can see that the number of equivocal cases was significantly reduced in up to 20% of the patients by using PET-CTA. So the European guidelines recommend the use of FDG PET along with WBC SPECT-CT in patients with prostatic valve and suspected infective endocarditis with the modified Duke criteria defined possible IE or rejected IE but high clinical suspicion. Then which one should be used, FDG PET or WBC SPECT-CT? Interestingly, these two nuclear imaging modalities have opposite diagnostic characteristics in the diagnosis of infective endocarditis, FDG PET being sensitive and WBC scan being specific. So FDG PET can be used for screening for the presence of infective endocarditis or other infection sources or extracardiac infection emboli. And WBC scan can be used for the confirmation of infection versus non-specific postoperative inflammation. However, it should be remembered that FDG PET CT performed early after surgery can show non-specific postoperative inflammatory activity, so it should be used at least 3 months following surgery, according to the 2015 Esc Guidelines. The most recent American guidelines has the same recommendation, but there is no specific recommendation regarding the use of WBC SPECT-CT. Here's a case from our institution. This 73-year-old gentleman was admitted for the management of recent cerebral infarction, and he had undergone the mitral valve replacement, and it was about 8 years ago. And the echocardiography showed very equivocal findings for the presence of valvular vegetation. So, due to the equivocal diagnosis of infective endocarditis, FDG PET was performed, and you can see on the MIP images, you can see the focal activity in the middle of the chest, which corresponds to the prostatic mitral valve. And the SUV max was 4.1 at 1 hour, which increased to 4.8 after 2 hours. And on the coronal view, you can see that the uptake is co-localized to the mitral, prostatic mitral annulus. When interpreting the FDG PET images in the evaluation of infective and prostatic valve endocarditis, the intensity and distribution can be important clues for differentiating infection from nonspecific postoperative inflammation. The infection tends to have more intense and heterogeneous and focal uptake, and in contrast, inflammation tends to have milder uptake, which is distributed homogeneously and diffusely along the valvular structure. Also, the location of the uptake can be another clue for differentiating the two, but although the spatial resolution of the PET can be a limiting factor. So, here you can see a ring-like uptake, which is quite homogeneous and diffuse along the valvular ring, which is highly likely to be non-specific inflammation. But in contrast, here you can see a very intense uptake, which is focally located in one side of the valve. So it is more likely to be infective endocarditis. The last part is about the use of bone scintigraphy in ATTR cardiac amyloidosis in aortic stenosis. ATTR-ACT study showed significant prognostic benefit for tafamidis, a TTR stabilizer, as compared to placebo in patients with ATTR cardiac amyloidosis. This study has brought great interest to bone scintigraphy in detecting and subtyping cardiac amyloidosis non-invasively. However, this is not a brand new story. The use of bone scintigraphy for detecting and subtyping cardiac amyloidosis has been well established since Perugini found highly sensitive and specific performance of technetium DPD bone scintigraphy in cardiac amyloidosis. Here you can see that the differentiation by the cutoff of visual grade 2S positive showed sensitivity and specificity 100% for differentiating ATTR cardiac amyloidosis and AL cardiac amyloidosis. And more recently, technetium-99 and pyrophosphate, PYP, also showed very excellent results for distinguishing ATTR versus AL cardiac amyloidosis, with this sensitivity and specificity reaching 100% by using the cutoff of heart to contralateral lung ratio over 1.5. The HCl ratio was measured by dividing the activity from the heart with that from the lung, with the same size of region of interest on the planar anterior view imaging. So the current multi-societal expert consensus includes 3 bone scintigraphy tracers, PYP, DPD, HMDP, for the clinical diagnosis of ATTR cardiac amyloidosis without endomyocardial biopsy. But you should remember that MDP is not to be used because of its low sensitivity for detecting cardiac amyloid. Recently, ATTR cardiac amyloidosis is being frequently observed in patients with aortic stenosis. In this study, among the 200 patients undergoing TAVI, 26 26 patients showed positive bone scintigraphy, indicating the presence of ATTR cardiac amyloid, which was associated with significantly higher levels of NT-proBNP and cardiac troponin. And the patients having ATTR cardiac amyloid was found to benefit from TAVI compared to medical therapy alone. However, there was no significant difference in mortality between patients with and without ATTR cardiac amyloid. And in another recent study, the prevalence of ATTR cardiac amyloid was similar, being 11.8% in patients undergoing TAVI, and they found a borderline significance of difference in the mortality between patients with and without ATTR cardiac amyloid. And they also found that the TAVI showed a better outcome as compared to medical therapy, well, regardless of the presence of cardiac amyloidosis. But within the same treatment strategy, the presence of ATTR cardiac amyloidosis was not associated with the survival outcome. This study also analyzed the risk factors associated with the presence of ATTR cardiac amyloidosis, including carpal tunnel syndrome, ECG changes, and other echocardiographic parameters. And they found that these risk factors could predict the presence of cardiac amyloidosis combined with aortic stenosis with the accuracy of 85%, and the scoring system can be used for indicating the need for amyloid screening with bone scintigraphy. Thank you very much.
Thank you very much, Dr. Sang Kyung Cho, for very wonderful presentation. And now I think we have just about 2 or 3 minutes for the discussion.
Okay, so I don't know, do you think we need all of these techniques to, I mean, like, do we need CMR, CT, nuclear, and echo for every patient, or should we, I mean, is this going to be too heavy and we need to select the population who undergoes one or the other test? What do you think, Mark?
I think echo remains the gold standard, and we should use echo first. And then I think at the moment we should pick other tests where we're not sure on the echo. And so, CT calcium scoring is a great example. I think it can be difficult when the echo assessments are discordant, and I think calcium score is a great alternative now. So, but we don't need it in everyone, and I think it's just being selective. At some point, we may say, well, we'll go straight to calcium score and we'll skip the echo, but we're definitely nowhere near there now. So I still think echo is your first test. I think with MRI, I mean, we've both done a lot of research in that, Bernard, and I still don't use it clinically for decision making, if I'm completely honest. We do lots of research in it, but we don't really send people for MRI to make clinical decisions at the moment. There's a randomized controlled trial happening now, and if that shows a benefit, then we will use MRI. In terms of PET, I thought the talk was brilliant, so thank you for summarizing everything. I'm not sure it has a role in aortic stenosis because I think CT is very powerful, and I don't think PET really beats it. The exception for that is if you're doing trials, and I think PET is a good endpoint in clinical trials to assess whether the drugs are working. But I think where it might have a clinical role is in bioprosthetic valve assessment, because CT and echo struggle to assess bioprosthetic valves, and PET is very good and reliable and offers powerful prediction of future problems. So there's that one paper we published in JACC, but there's a paper just coming out in Circulation looking at TAVR valves, and it's equally effective in TAVR valves. So I think that might have a clinical role. But the whole idea of multimodality imaging is that we don't throw all the imaging tests at everyone. We're selective, and we pick the right test for the right patient at the right time. And I think we have to do that. And the starting point is echo.
Yeah, I thought it was also very interesting in the talk from Dr. Shou that you have like clinical risk scores, like from biomarkers or something like this, like seeing troponin or seeing echo red flags for going to look for amyloid. What do you think, Dr. Shou? I think that looks like a very good strategy. Huh?
Thanks for your question. Yeah, I completely agree with your opinion that this is a very good approach. Because there are just only around 10% of patients having cardiac amyloid undergoing TAVI, so I don't think all the patients will need the bone integrity study prior to TAVI, but the risk of the patients having cardiac amyloid is a little bit unclear because the cardiac events rate was at a borderline, had a borderline difference with those not having cardiac amyloid. So maybe some more treatment strategy using TAVI plus tafamidis, for example, will more clarify the value of bone integrity in patients undergoing TAVI.
Yeah, a quick comment about that. I mean, I think this seemingly high prevalence of amyloid is really in TAVI populations, and I'm not sure that's a surprise because you've got an average age of people in their 80s, you've got 90-year-olds, and if you look just generally in the population of 90-year-olds, you'd probably find quite a lot of amyloid if you screen them, irrespective of their valve disease. We've done a lot of MRIs in patients who are not TAVI, just like standard aortic stenosis patients, average age 70. And I don't think I've ever, well, maybe one patient I've seen amyloid that convinced me in an MRI scan. So I think that prevalence personally is specific to that TAVI population because of their age. So, yeah, I want to do I'd love to do a study, like a big study where we looked at just general aortic stenosis patients and see actually how many have amyloid, because I think that proportion would be much lower. In terms of the biomarker thing, Bernard, I totally agree actually. And as part of the EVOLVE trial, you don't get an MRI unless your troponin is elevated. So if your troponin is normal, i.e. less than 5, then you don't have an MRI scan. And I think this combination of biomarkers and imaging, particularly advanced imaging, makes a lot of sense because we can target the expensive imaging modalities just to the people that really need it. And I think that's a cost-effective strategy, as Dr. Cho said.
Dr. Y, how is it? I don't know. In Vietnam, do you think? Even. We wouldn't even have access to all patients like to go. I mean, there's so many patients having aortic stenosis. I mean, we wouldn't even have access to send all these patients to MRI because how would it be actually in Vietnam, or is there access to these advanced techniques? And do you think you can use this in your settings?
Thank you very much for your very practical question. In Vietnam, now the population is aging, and the prevalence of aortic stenosis is increasing, and the medical insurance pay for the cover the cardiac MR. So I think in the near future we can indicate cardiac MR for the patient with aortic stenosis. If I think the first step that we can indicate when there is discordance between echocardiography and symptom, and to finalize the diagnosis of the patient, and then we can think about evaluation the cardiac function and prognosis of the patient.
Yeah, I think also the what seems very logical, I mean, to me, is also the approach which Mark proposed, that you look for actually ECG changes to look for fibrosis, that maybe we will be able when we see ECG strain modifications, and that these patients may be also having a higher risk, and that these may be the patients actually who need an MRI to undergo fibrosis screening. That seems also a very interesting approach.
Thank you.
To select the patients who need these advanced techniques.
Yeah, I agree, Bernard. I mean, the strain, I really pay attention to strain on the ECG now. In the study that we did, everyone who had strain had myocardial fibrosis on their MRI scan. So I think it's a very specific marker. It's not very sensitive, so you'll miss people who have myocardial fibrosis, but it is very specific. So I think when you see it, I think you have to be concerned that the ventricle is starting to decompensate and to struggle. I agree.
I totally agree with you on that we should apply cardiac MR for patients if we want to look for cardiac fibrosis. Yeah.
Do we have any more questions, or do we have to close the session because I think we are at the end of the time?
Yes, I think we are at the end of the time, and Professor Gerhard Gerber, would you please?
Yeah, I would like to thank you all actually for this excellent presentation. This was very good session. I think thank you very much, Dr. Roy, Dr. Show, Dr. Dweck. I mean, all these presentations were really very interesting. I think we could sit here for debating for hours again, and it was. Thank you very much for the invitation to be here, and I would be really looking forward to further sessions and see how this is evolving in the future.
Thank you.
Thank you very much. Thank you for the invitation.
Thank you very much.
Have a
with immediate access to potential users around the world. Bayer is illuminating the path forward, generating results from a world full of potential. We're excited for the journey ahead. Let's take the next step together. We want to meet you. Schedule a meeting to share what you're developing.
My journey continues, and I know I'm not alone. Because together we can make a difference every day.